intervention straight away. And then we'd spend the next 2 hours sort of going through therapeutics of why that probably was the case. So I'd ask them, I say, ACE inhibitors, what are they used for? And show of hands, high blood pressure. Anything else? Quiet, silence. And then we get on to, what does licensed indication mean? And so, that was my provocative start to training dentists.
I'm interested, Steve, you said GPs didn't know about it. The other non-medical prescribers did. There's another way of looking at that. If the GPs, and I'm sure they're perfectly competent prescribers, aren't using a framework like this, what's the point of a competency framework, would be my question.
Ooh, controversial. I tell you what, right? So I've started doing some legal work. I work as an expert, in inverted commas, around clinical negligence cases. And this is the sort of document that when I have to put together a brief for a barrister, I will use this document in relation to, when wanting to consider if somebody might have done something outside the virtuous circle of that, body of men/women in the classic trial. I use these kind of documents because they are accepted, they're endorsed by all those Royal Colleges, as we just discussed. So there isn't anything controversial in the competency framework. And if you have clearly done something that looks like wide of the mark, in other words, virtually nobody would probably have followed your route, then, you have to question whether or not somebody did even understand what was expected of them.
Yes, it brings together that set of standards that all prescribers should be working to. Everything is there. And you're right, if you prescribe outside of that, if you don't know what you're doing, if you haven't done an assessment of the patient, if you haven't checked their allergy status, if you prescribe something and then it causes harm and you haven't done what you should have done, then you're liable. And it brings together all of that. It's a crucial document for prescribers, not just non-medical prescribers, all prescribers, and it will help them to self-evaluate, look at their prescribing practice, and then improve where necessary.
What don't you like about competency frameworks then?
I suppose it's not that I don't like them, it's a sort of a questioning of purpose and evidence, really. I don't think there's much evidence about the role they have in improving practice, and in general, there's a tendency in health, isn't there, to try and break very complicated things down into lists and spreadsheets. So it's not that I don't agree with competency frameworks. I suppose I'm just asking the question to sort of get a sense of why they're so important. What I did like in it, there's a section in there about professionalism. So we know in a complex system, one of the things is about simple rules. And so there's a list of simple rules and I think this is probably more in line with how the doctors might sort of work. There's a list of rules, and it's, adapt consultations to meet the needs of different patients, undertake the consultation in an appropriate setting, take responsibility for own learning and CPD. And in a way, those simple rules are enough, you could say, to be a prescriber. I guess what the competency framework does, and that's why it's there, is expand on those simple rules to help people who need the help. So I don't disagree with them. It's just taking a questioning approach, really.
Pretty amazing that it actually only runs to 15 pages. I think that's the power of it, actually. As I say, there's nothing controversial in it, is there, Fiona? And as you've said, it does help you. I use it all the time. When I used to sit on non-medical prescribing committees, I used to get all these people coming through as new non-medical prescribers. And it was my job to put the fear of God in them, because they'd always put something on their P formulary, something that they said they were going to prescribe to begin with, which was pretty obvious that without even checking with them first, it wasn't something that they probably knew anything about. And I'd say to them, okay, so we're in a court of law, you've prescribed that. Would you like to explain to me why you would say you were competent to prescribe that? And almost 9 times out of 10, they'd go, well, the consultant I work with told me I need to put it on my list. I said, right, I think you can take that one off. And they go, oh, good, I'm glad you've said that.
Absolutely. And if you don't know what you're doing, you shouldn't be doing it. They need to be able to see the probable or possible consequences of what they're doing. And that's what accountability is all about.
So one application in this area, it's away from competencies, but it's all about it, is when, and I spent a long time looking at this over the years of people's propensity to prescribe a new drug. So over the years, when new things have come on the market, we know that sort of uptake follows the innovation curve, that you'll get the early adopters, and their reasons for prescribing it are very different then to the people that are prescribing it and who are watchfully waiting to see, waiting for more evidence, slightly risk averse. And so that whole conundrum of when do we adopt a new therapy, and it's obviously changed now with lots of the assessments that we do at national levels, but to see it as an individual prescriber level is fascinating, and it sort of maps across to some of the behaviours and traits then that you mention in competency frameworks, together with the knowledge and the skills.
I think the one thing I would say, if I wanted to be edgy, is I think the public would be shocked that all the people that prescribe, and we talk, don't we, about how does it take 16 years for people in healthcare to change and understand and move with the evidence? I think the public would be shocked to know that most people who are prescribers, whatever profession they come from, are not actually have to prove any continued level of competence from the day that they first were able to prescribe. I think that's wrong.
Well, I suppose yes. I mean, I hear what you're saying. I can speak as a nurse that the Nursing Midwifery Council do expect, well, all healthcare professionals are revalidating and doing that a lot more actively than probably they used to.
It's not mandatory though, is it? It's not mandatory to include anything about prescribing.
No, the NMC don't mandate that as part of revalidation.
And nor do any of the others. And that's the bit I'm saying I think is wrong.
The bit the medical college...
Yes, that is down to local level decision making. So, for example, non-medical prescribers working on the Isle of Wight, there is an expectation, it's in their policy, that they have to complete that competency framework and submit it to the NMP lead, non-medical prescribing lead, and if they don't do that on an annual basis, then they're not permitted to continue prescribing. But not all trusts will have that in their policy. I know other trusts where they say they would like that submitted every 3 years, and other organisations where it's not mentioned at all. It's down to the individual to take responsibility. So, it varies across the country.
The other addition to this debate, I suppose, and, me criticising or highlighting the criticism of the lack of training at medical undergraduate level. Now we've got the prescribing safety assessment, haven't we, that the medical schools buy into from the British Pharmacological Society. That's still sort of optional. There's a lot of work gone into the development of that over the last 10 years to bring these type of things. And so hopefully when this new competency framework comes out in the summer from RPS, then together with the work that we've done at medical undergraduate level, some of these things will start to join up. And any prescriber, wherever you are, the expectation will be that, as Steve said, this is what you turn to.
It can't move by osmosis or Brownian motion.
With that, we'll move on. A big thank you to Fiona for joining us on The Oral Apothecary and for sharing her desert island drug, her career anthem and her book. Coming up next time, we'll be joined by Lely Obo. Lely became the first community-based consultant pharmacist in 2007. Her role involves optimising medicines use in frail older people within integrated community-based multidisciplinary teams, including general practice, care homes, district nursing, intermediate care teams and geriatrician-led virtual clinics. We look forward to welcoming Lely next time on The Oral Apothecary. Over to Gimmo now for our contact details and the final ingredient.
And thanks for me, Fiona. That was fantastic. So contact us on Twitter at Oral Apothecary. You can email us at oralapothecarypod@gmail.com. Our social media shout out. Just a reminder again to vote for us in the British Podcast Awards. I think you can vote until July the 10th. I think that's right. So get on it. And a big shout out to Paula Phillips, who is also a nurse, and she's part of a brilliant team in Improvement Cymru who I work for, supporting people with learning disabilities. Jamie, she's asking me, when are you going to do the Julian Tudor Hart story? Unfortunately, we haven't got time for that tonight, but we will hear it sometime.
Well, Paula, look, there's not just Julian Tudor Hart. There's My Dinner with Ruby Wax. What Did I Say to Don Berwick as we shuffled into Cardiff City Hall? These are all stories that hopefully one day I'll get to share with our listeners.
Okay, so final ingredient. So a big feature of our show is the Oral Apothecary playlist. We've had another fantastic song from Fiona tonight. What if I told you that it might have a use as a medicinal product? That's right, I'm talking about medicinal playlist prescriptions. So a company called MediMusic is exploring this in greater depth. And they claim music has been proven to reduce anxiety by 44%, pain by 29%, and has even resulted in a reduction of the need for drugs by 24%. They're involved in a program that creates individual playlists designed to reduce heart rate and influence the vagus nerve to stimulate a positive physio-endocrine response. In other words, a prescription to relax and cheer you up. So there you go. The Oral Apothecary is not just a podcast, we are a prescription for happiness.
This was a 3 Apothecaries production. Sound engineer Jimbo Slough. Original music Jamie Brewster. Artwork by David Baker.
Thanks for listening to the Oral Apothecary podcast. Warning, always enjoy with an alcoholic drink, especially if operating machinery.
This episode of the Oral Apothecary is sponsored by jamiehayes.co.uk.